We'll change the sequence of the talk. Now that we have Dr. Yunia here, we will get started first from the outside in rather than going from inside out. So we'll get started with the reconstruction of the upper eyelids, and as we do know that eyelids form a very protective barrier to trauma and all. So let's see how Dr. Yunia, through her surgical skill, restore the eyelid back to normal to prevent the glow from the trauma, further trauma. Thank you, Dr. Yunia.
Thank you, Dr. Rupesh Agarwal. I think, good morning, everyone. I'm very happy to join with all of you in the APOTS session. This is a trauma session, I think, for me. This is the first time I come to Dubai, and I'm very excited to be here and sharing with all of you. In my subspecialty is oculoplastic, but I do a lot of case trauma. Because there was any change the schedule, maybe some of our speaker doesn't hear yet, and then I would like to starting this session.
Yeah, get started. Yeah,
okay, thank you. Yeah, my title now is Reconstruction of the Complete Upper Eyelid Avulsion. There is no financial for my presentation, and as I have reported from our police state of Indonesia, the report of the accident is more 100,000 in 2020, and causing a side injury more than 10,000. And more than 100,000 people respectively. I think the ocular injury is the second mostly caused by motor vehicle accident, and it's lead to severe ocular injury. The prognosis of eye injury is highly determined by the initial damage and by availability of the treatment challenging in my result in various outcomes. Sorry. Okay. The previous literature states that more than 90% ocular injury were mild and did not treated with a visual acuity. But from the epidemiology study conducted 1994, reported that 12% of the eye involved from the 150 motorcycle vehicle removal. And I think a choice for reconstructive surgery for the last facial defect, that in my case, should be based on the reconstructive leader with the consideration of each procedure advantages and disadvantages. My case is 22 years old. Okay, a female come to us with being involved by car accident 3 months before. And for our examination, please, I don't know. This is when we can see the total upper eyelid avulsion with the necrotic facial defect. The visual function was irreparable due to the perforated cornea and possibly with the traumatic optic neuropathy. And here we can see the total upper eyelid avulsion and non-function eye. The eye become physical, and there was large necrotic facial defect. From the CT scan, we can see the frontal and facial bone defect. I don't know why she's not running well. And I think the aim of our surgery to prepare a good socket to achieve desirable prosthetic position and cosmetic feature. So we performed the evisceration with inserted with a dermofat graft implant, reconstructed the posterior lamellar and eyelid with buccal mucous graft, and then addition with the large facial defect reconstructive. We collaborate with the plastic surgeon to perform the anterolateral tight free flap in the one-step surgery. Oh, sorry. Okay, this is my video during the surgery. After we take out all the content of eyeball, and then we are make it relaxing for the scar tissue. Oh, I'm sorry. I don't know why. Sorry. The video. Okay. Yeah. And then I put the dermofat graft for the implant.
Can anyone please, audiovisual team?
It's because the conjunctiva is not enough to covering all the graft. I think should be better to preserve all the fornices. And then after that, I make it the posterior lamellar graft with a buccal mucous graft to covering all the posterior lamellar in here. Before that, I inserted the conformer. Okay. And after I covering all the socket with mucous membrane graft, and then the surgery continues with our colleagues from the plastic department. And they took the free flap from the anterolateral tight free flap because we need the huge anterior lamellar for covering a quadrant about the facial defect. I think this is a post-operative. They're covering the donor side with the skin from the abdominal. This is the post-operative picture. We can see the free flap is very used, and by the time they do the liposuction to make it the skin thin, and then the appearance with the similar with another side. And after surrounding 6 months, I put change the conformer with the prosthetic eye. And this is a post-operative, 1 year and 1.5 years. And they do the implant for the brow also. And I think that the tissue involvement, the ocular injury, determine the prognosis and anatomical and visual function as well as the initial damage treatment given. Aside from the aesthetic value, upper eyelid is critical, important to perfect the globe because the eye cannot survive for long without it. And main principle of the eye reconstructive is perform three components: outer layer, skin, inner layer, mucous, and the semi-rigid skeleton in the middle. It is impossible for the defect with the bone base to use the skin graft, which is a simple technique. Therefore, we do the free flap in as option. And the free flap was considered to be the superior because the donor defect did not appear to the face area. And with the application of anterolateral tight free flap, the donor defect could be hidden. And the technique is difficult because it requires transfer of the live tissue by blood vessel size 1 until 2 millimeter requires through the evaluation of the successful result. I think we should be observation until 3 days post-operatively. In my case, the free flap was accompanied by an administration of heparin due to the strong recipient artery flow and smooth recipient varus drainage with a large enough perforator caliber. This patient, we unfortunate to have a total eyelid avulsion with extensive skin loss for 3 months before being brought sick with the ophthalmologist. The visual functions in this patient could not be restored by the extent of damage of the corneal and exposure secondary infection, probably with the optic nerve injury also. Then the goal was made appropriate for the prosthetic position. And I think for the take-home message, eyelid and facial injury often result in visual loss, but we can do explore with the RRD or VEP first, and then various aesthetic problems rising considerable cost. The main objective of reconstructive procedure are to improve the patient quality of life and improve the cosmetic function. Even though the visual function of the eye could not be restored in severe condition, but the objective of the reconstructive procedure are make reconstructive of the eyelid and stable to support the ocular prosthetic and reconstructive the periorbital area with a versatile tissue. And the main principle of eyelid reconstructive of the complete upper eyelid avulsion with a broad defect, I think there should be combination of the graft with the flap uses. Also, the thickness of free flap should be adjusted with the eyelid contour. The free flap was considered to the superior in this case, and we choose the anterolateral tight free flap in one-step surgery, not free flap origin from the arm, because the reason that is has plenty of the vascularization and white area. I think, thank you for your attention.
Thank you, Dr. Yunia, and for saving the globe, saving the eyes, and saving APOTS and our face. Thank you, and sorry for the technical glitch. While I invite next speaker, Professor Rekha Khandelwal from Nagpur, Central India, to give a talk on open globe injuries, a question to Dr. Yunia is how frequently you encounter such a bad total eyelid avulsion or a very bad eyelid injuries. Is it quite common?
Thank you, Dr. Rupesh. I think it's, yeah, in traumatic injury, I think contribution for the eyelid from the simple eyelid rupture to the severe condition is huge number, but usually only the simple with the canalicular involvement. But some cases with my case presentation today, I think this is a rare condition with a quadrant part of the facial is lost. Yeah, the patient doesn't come to us earlier because they left in the peripheral area. Yeah.
So that's great, and fortunately we don't have that many high prevalence, and other lead injuries can be managed, but I think getting oculoplasty on board early is more better. Probably that is another message I will give, because sometimes as an anterior segment surgeon or as a retina surgeon, we might not be able to do full justice to the late surgeries, and it will go on and it becomes a very difficult surgery for the oculoplasty surgeon eventually. So I think full justice they need for the late reconstruction, right, Dr. Unia? It should come to the oculoplasty people early. Now we'll go to the other common topic, which I think is very important for this audience here, is the management of open globe injury. I know that every one of you manages, but let's hear from one of the world's expert on this open globe injury from Professor Khandelwal. Thank you.
Thank you, Rupesh. Good morning, everyone. So I'm sharing my experiences from Central India. It's a rural-based teaching hospital. So we know that the trauma terminology is given by Betts in 202 by Ferenc-Kuhn, and the open globe is divided into rupture and lacerations. And lacerations are further divided into penetrating, perforating, and intraocular foreign bodies. And then there are zones of injury, like zone 1 injury is cornea and limbus, and if it is beyond till 5 mm, we call it zone 2 injury, and then zone 3 injury is beyond it. When we deal with a case of open globe injury, we have to adopt a systematic approach starting from history, vision, and laceration to intraocular pressure. So history is very important in all the open globe injuries, and details about the history, when, where, how it happened, the agent causing it, any previous ocular or systemic disease is important, as well as previous ocular surgery is important. Like this patient who presented with us had history of penetrating keratoplasty, and you can see the wound has gaped completely with the history of trivial trauma. Also assess adnexa, lid, and conjunctiva, as Unia told you. Involvement of canthi, position of puncti, lid margin, all are very, very important. As well as extent of subconjunctival hemorrhage, especially deals with zone 3 injury. It gives you idea that it can be zone 3 injury. And this was a case of blast injury at home while cooking on a coal burner, and you can see extent of injury. Visual acuity on presentation has prognostic importance as well as medico-legal importance. And sometimes vision cannot be recorded, especially in cases of bilateral severe injury, but the reason must be documented for medico-legal importance. Seedal test is important, as you all know. If it is open globe obvious injury, there is no need to do seedal test. But sometimes there is a self-sealing wound and AC is formed. In those situations, do perform seedal test. With pressure also try to perform seedal test. And if it is positive, the patient might need glue BCL or suturing. About corneal laceration, the extent of laceration you must document, like this was a full thickness, limbus to limbus, linear corneal laceration of 10 mm in length and with uveal prolapse, especially involvement of limbus infection at the edges of the wound is important to note. Note the viability of prolapsed iris and also document with drawing. So in our hospital, we teach residents to draw the drawing of all the open globe injury, because these details are very, very important for the management of patient. So along with photograph, also make a habit of having drawings when you have open globe injury. We know that there is shallow anterior chamber in open globe injury, but there can be deep anterior chamber, especially if there is a posterior occult rupture. And this was a case of 20-year-old who had trauma, and you can see a blood clot and vitreous in anterior chamber. So there can be abnormal contents like hyphema, fibrin, foreign body, loose cortex. You know, the teardrop pupil is very typical of open globe injury. But do not forget to record relative afferent pupillary defect, and also if there's a severe injury, record the reverse RAPD, which is very, very important. Look for traumatic cataract, intact, torn, or torn capsule or broken capsule. Lens may be partially absorbed. Look for foreign body in the lens and status of posterior capsule if possible. Intraocular pressure is usually low in open globe injuries, but do not try to perform tonometry in open globe injuries. So pre-op assessment, we have to note the nil by mouth status, tetanus, start antibiotics, record guarded prognosis, get CT scan, but do not do MRI. Plan repair as early as possible under general anesthesia, and if that is not possible, you can try local or with sedation. This is a zone 1 injury corneal laceration. The sutures should be at even distance on both the sides, right angles to the wound, and with no touch technique, the suture depth is at 90% and not should be buried away from visual axis. This is another case of zone 2 injury where the first suture is taken at limbus and then go on suturing the cornea, bisecting the wound with 10-0 nylon. And then in the end, you will see that the sclera is sutured with 8-0 vicryl. This is a scleral laceration zone 3 injury. Here you have to identify the scleral folds, approximate true edges. You may have to explore the muscle, and it is better to repair such large wounds with VER surgeon if possible. Iris prolapse is an important issue because you have to conserve as much as possible, and if it is 6 to 12 hours old, you can repose it gently with viscoelastic or with spatula. If it is necrotic, non-viable and contaminated, it must be excised for the risk of endophthalmitis. Lens involvement usually is avoided during primary repair unless there is a flocculent cortical matter in anterior chamber. So if the laceration involves limbus, always do peritomy. The first suture should be at limbus. Rotate knots away from the visual axis. Take central suture shorter than peripheral ones and fix anterior before posterior prolapse. Do Seidel test at the end. Also remember what you should not do, and that is do not hold the edematous edges of the wound and pass suture. Do not over tighten the sutures. Do not inject through the entry wound. Do not overload anterior chamber with viscoelastics or with fluids. Postoperative care involves antibiotics, cycloplegics, steroids. And in globe repair, aim for maximum possible visual outcome with good cosmetic and structural integrity of the eye. Thank you very much, APOTS and Dr. Rupesh.
Thank you very much. Thank you very much, Professor Khandelwal. I'm sure Dr. Elamri will realize that trauma will require probably half-day session, if not one full-day session. The 1 hour might not be enough. But there are questions, while we request Dr. Purindra Bhasin to be setting up his presentation on traumatic cataract, and which I believe after the management of open globe injuries and late repair comes into the picture. So Dr. Khandelwal, question to you. I think you've shown some very beautiful videos and illustrations. That's very important. I do know that here also there are people who repair. So do you think who should be the one repairing the open globe? Should it be the junior most doctor, the senior doctor? And what do you rationalize and what's the best way? And you come from a teaching institute. So maybe in short, in less than a minute, maybe you can give some flavor to our audience here. What should they do when they come?
I think the senior doctor must do the corneal repair. When I passed out, it was the dictum that the junior doctor should repair. But then it leads to the thesical eye and bad suturing and astigmatism. And we aim for integrity of the eye to lessen the astigmatism. But we can train the junior doctors under us. And in our college, we always try to repair all these wounds with the senior doctor, and junior doctors usually assist us, and we give them sutures in between when we are doing suturing. So we take primary sutures, then we ask them to take 1 or 2 sutures in this way. It's a basically teaching through a long learning curve, I think. But trauma is important and should not be left to the junior doctors unattended.
So one question.
Thank you very much. Yeah, Dr. Basi.
Dr. Rekha, for everybody, when do you want to do the surgery? If the patient has come at 10 o'clock in middle of the night or 11 o'clock or so, so what do you recommend? Should be done in such setting or?
So we usually do it next day in the morning
Electively.
when the OR is ready, when the VR surgeon is available, if in case we need. So we usually do not operate at night, but do in the morning if it is at 10 at night or 11 at night in our institute.
So
We
that's
we
what
prepare
actually,
patient for the morning and then we do it. But the senior doctor should be available. That is our first requirement.
I think message is that we can wait. It should be done in an elective way. Thank you.
Thank you, Dr.
And,
Basi.
thank you,
Cataract.
Dr.
Yeah.
Muhammad Al-Amri, for inviting me, and Dr. Rupesh for organizing this APOTS session. I am Dr. Purendra Bhasin. I have no financial interest. So management of traumatic cataract is really a very important issue because it has to impart a good vision. But before we take the case, we should plan it in a way that whether it has to be done in a staged or a single sitting or a comprehensive surgery, we require a VR surgeon or a glaucoma surgeon along with, we should discuss with the team. And what and how urgent is the initial surgery and optimal timing of each surgery, because all these cases, they usually come late or not on the very first day itself, and they develop, they are having glaucoma, they are having uveitis, they may be having a reaction in the antechamber, some infection on the surface, and all these things should be taken care before taking the case for the cataract surgery. And we should share the plan with the team, and we should always have a backup plan also. So now this is a young 7-year-old child, play the video please, who has developed the cataract and there is a ruptured anterior capsule. We should avoid doing hydrodissection in all these cases because you never know what is the status of the posterior capsule. And after cutting the anterior capsule fibrous margin with the scissor, as you can see here, the anterior capsule is cut in a circular fashion like we do a capsular axis. And all these young children, less than 10, 12 years, or even at 12 years, I do posterior capsular axis because chances of opacification of the posterior capsule in all these cases is very, very high. And if you don't do posterior capsular axis, the posterior capsular opacification will lead them to the amblyopia. A 3-piece lens is placed inside, and we are engaging the optic of the lens and into the posterior capsular opening. And the chamber is filled, and it's a no suture technique. This is the post-operative picture of the same patient with the optic capture of the PCIL with well-centered IOL, and the vision is, even at 1 year, is 6/6. Another young patient, and can you play the video, please? Can you please play the video? Thank you. This is the anterior synechias are there. It's a dense, and whole of the iris is adhered to the periphery of the cornea and to this scar of the cornea. So what we do with the bimanual micro instruments, we remove all this, the muck, and make an opening in the, enlarge the pupillary region so that the light should go, adequate amount of light should go. And I'm doing a posterior capsular axis because the child is 6 years old. So, and all these reactions are there, and in immediate post-operative period, we expect too much of reaction in this case. And the PCIOL, 3-piece PCIOL is placed in the sulcus. Expecting the chances of glaucoma, I did PI with the help of retractor. This is very interesting case. 35 years old male had a penetrating corneal trauma. The corneal tear repair was done and 8 months back, and the patient came to us with the when he has the -16 diopters of cylinder at 173 degree. At 8 months, we planned, when the refraction stabilized, we planned 11 diopter correcting toric IOL, and we did a phacoemulsification. As you can see here, there is a -16.18 diopters, and this was done way back in 2012. This is the case. Can you please start the video. Yeah. So I'm releasing the stump of the iris adhered to the anterior capsule, and anterior capsular axis we are doing. Hydrodissection is done. Now here you have to focus. While I was doing the I&A, there is a strand of vitreous there. So in this region, there is a zonular dialysis. So to make the capsular bag stable for the long term, we place this aniridia ring segment, and this will work like a CTR, as well as it will cover the area of the iris. This is an 11 diopter correcting IOL. At that time, only Rayner was producing such high power correcting lenses, and this is a hydrophilic acrylic lens with a 6.5 millimeter optics diameter, large optic diameter. So this is how we we corrected this, and we did the surgery. And patient had, at the end, after 6 months onward, patient had 1.5 diopters of cylinder post-operatively, and he was having very good vision, because the central cornea with the cylinder decreases when we are looking at the central 2 millimeter zone of the cornea. This is very interesting case we did this year. 17 years old male came with a blast injury, firearm blast injury, with both eyes PL/PR vision. And in left eye, the pressure was 40 millimeter mercury, and both eyes post-penetrating injury, multiple embedded corneal and scleral foreign bodies was there. And in right eye, the corneal tear, which was sealed, and in both eyes, there was a mature traumatic cataract with ruptured anterior capsule, and B scan showed intraocular foreign bodies, as you can see in both eyes in this thing. So this is the video. Can you please start video? So we took the left eye first. We were doing without doing hydrodissection. We started with the phacoemulsification. We saw there is a foreign body which is there, and there is a ruptured posterior capsule. And with the help of retractor, we are removing the cortex and tried to engage the foreign body, but it went into the vitreous cavity. But good part is that our capsular axis is intact. 3 days later, my retina team, they planned a TPPV, and the foreign body was removed. Then we took the right eye, and with the experience of left eye, which we failed to engage the foreign body from the anterior route, we did with infusion. We placed the infusion 4 millimeter away, and the corneal tear, which was looking sealed, but we repaired it. We put sutures, and with the help of retractor, we removed the cortex, and this foreign body is now placed over the surface of the iris. And because there is an infusion behind, so there is a iris prolapse here. We should do it from the second port, and after suturing the wound, paracentesis wound, with the help of retractor, I am removing all the cortex, and the corneal tear is also repaired, and there is a deficient posterior capsule, and anterior capsule rim is also not there. So after 10 days, after 2 months, the left eye, the previous eye, we did the PCIL in this case, and after releasing all the adhesions of the iris and the anterior capsule, which was intact there, a 3-piece lens is placed in the right eye. And this was the easy thing. And now coming to this was in the left eye, now coming to the right eye. So because there was a deficient posterior capsule, we did a modified Yamane technique, as you can see here, and 3-piece hydrophobic acrylic lens is placed. It's a lens from Johnson & Johnson, no financial interest. A flange is created, and the other haptic is now engaged in the 29 gauge or 27 gauge needle, and a flange is there created, and it is well-centered lens, no suture in all these three. So this was very, very satisfying for both patient and for us. Now the post-operatively, the right eye, the corneal scar with stable IOL and retina, which was done by the modified Yamane technique. And in the left eye, cornea was clear, and eye is quiet, and stable IOL is there, which is placed in the sulcus. So right eye best corrected vision is 612, and the left eye it is 69. And there is some residual refractive error in right eye, which may be taken care by the laser if needed, if patient is willing. So last case, 32 years old female, very interesting case. She came to us with the defective vision in left eye for last 9 years. Right eye vision is 6.6, left eye refraction is 3.5 with 4.5 diopter cylinder at 60 degree with the best corrected vision of 612. Now this is very interesting that the patient was advised LASIK laser for the left eye somewhere else. And she came to me to get her refractive correction done. So, this was unusual to me because on pentacam tomography, we didn't see any cylinder. And that was, then we dilate the pupil of the patient. So this is very important. And under dilatation, we saw that there is a nuclear sclerosis with early posterior subcapsular cataract, and the lens was subluxated. So that was the reason for the induced cylindrical part. And then she gave the history when we checked retrospectively that 11 years back she had a trauma, trauma to the eye. So we planned the cataract, laser cataract surgery assisted phaco with Sioni ring. So this is what we are doing. Oh, sorry. Can you please start the video? This is with the laser cataract surgery. This is the reason of the subluxated lens. And we modified because the capsular axis could not be made of 5 or 5.1 millimeter. So we made it as 4.6 millimeter. This is on the surgery table. We have made a groove there to fixate the Sioni ring to the sclera. And anterior capsule is being removed. And with the help of the phaco, we are removing the nucleus part. And then because there was a subluxation on that, in that region and the chances of vitreous which is coming. So with the help of vitractor, all these things if we do with vitractor, that helps us and that helps us in managing the cutting the vitreous and removing the cortex simultaneously. Sioni ring is placed inside, and proline suture is tied to the haptic of the Sioni ring, and this proline suture is railroaded out at the sclera 2 millimeter away from the limbus and tied to the sclera. Now a single piece lens is placed inside, and this haptic of the Sioni ring will remain in the anterior chamber. It will be. So this is the post-operative picture, and the patient's refraction is with 6.9 best corrected vision with 0.75 diopters of cylinder only. So this is the, if the time permits, can I show one more case? It's just 1.5 minutes.
Yeah. Okay.
Thank you. So this is a grossly subluxated lens, as you can see here. So we plugged the vitreous with the help of viscoat, no financial interest, and we did capsular axis. In all these subluxated cataracts, what is important is the capsular axis should be done on the center of the lens, not in the center of the eye. So it will be eccentric, and you can see that the lens is subluxated here and in this region also. We have fixated the lens with the help of capsule retractors, and it's not a normal soft cataract, it's a grade 3 cataract. So as you have seen in the previous case, and I have done almost 200, 300 cases of this kind in my 20 years of experience. I placed the Sioni ring inside and in the bag. The haptic is being sutured tied to the sclera 2 millimeter away, and this is the more important time to focus here, please. I need your attention. That while tying the knot to the sclera, I over-tied it. Now what happened, that this is the region where the subluxation is there, and we have created iatrogenic subluxation in this region also, in the opposite part also. So I was very much depressed because after doing all this surgery, I just changed this thing, and then I released the knot there, and what I found is that there is this rent is there, and now I change this thing. I am passing a suture, proline suture with 2 straight needles. One straight needle has gone through the haptic of the eyelet of the Sioni ring, and the other is now again passed through the sclera. So now Sioni ring is fixed with 2 proline suture haptics, and it is tied to the sclera, and a 3-piece lens is placed in the sulcus, and the optic capture is done in the anterior capsular axis. This is very important that we have done optic capture in the anterior capsular axis. Otherwise, this lens could have slipped from the area of the zonal dialysis in this region as well as in this region, which we have hydrogenically created. So, friends, so we should always have a plan before treating a patient with a complex injury. Any intervention should be dictated by what is best for the eye, not by what is possible by the attending ophthalmologist. And we should be ready for any intraoperative surprises and anticipate problems, as I have shown in my last case, and that may occur. And we should always, therefore, have a plan B ready to execute what is necessary. Thank you for the patient hearing.
Thank you, Dr. Bhasin. While I request Dr. Vivek to set up his presentation, Dr. Bhasin, I think you did not put up a disclaimer properly that people with the weak heart like me should not be watching these videos. These were really Tom Cruise-like stunts, the Mission Impossible. I think you should have put a disclaimer. Anyway, amazing videos. Just maybe you can
Please,
Dr. Bhasin, you can come here. And just while Vivek is setting up his presentation, just some tips for general ophthalmologist surgeons like us who do not operate such complicated traumatic surgery. If we end up having such a case on our table, should we postpone, or if we are not able to repair, what is the best advice? As you said, we should do best for our patient, not best what we see in our hands.
I think all this is possible with an experienced surgeon. Anybody can do it. Only thing is you have to dare to do, and you should have all these things available in your surgical setup with you. Otherwise, it's not, and you should have time, because nowadays what we have seen is that surgeons, they say that we do phacoemulsification, we finish it in 7 minutes, 5 minutes, 10 minutes, and there are 10, 15, 20 cases lined up. So why should I indulge myself in such kind of a surgery? And better it is that I finish all my cases and do the OPD. So you should have you should take such cases. Maybe you can take it again. You can stop there, explain the patient, and arrange everything, and then you can take the case at leisure when your OT list is smaller. So, but what I feel is that scleral fixated lenses and secondary IOL, they are definitely going to give an edge to your practice, because they will be rotating here and there, and without their successful outcome, they will not be comfortable, and that is going to give you an edge from others when you are doing such cases and giving good vision to these patients. My one important thing is that always manage vitreous. Take the vitreous as a tissue. It's a whole tissue. Like a conjunctiva, like a cornea. It's not a, what we are seeing, it's not a fluid. It's a tissue which is attached behind at the optic disc as well as at the periphery and at the macula. So if we are not cutting it with the vitractor properly, it is going to give you a lot of problems in the immediate and late post-operative period. Thank you.
Thank you very much, and these are very useful tips, and once again, congratulations for all the great work you've been doing. Thanks. Over to Dr. Vivek, who comes from Hyderabad LV Prasad Eye Institute, one of the young dynamic retina surgeon, and who is very active in trauma work with Asia Pacific Ophthalmic Trauma Society as well as International Society of Ocular Trauma. He set up a very nice clips called as trauma clips from his APO LDP program, and we'll watch his surgical stints here. Thanks, Vivek.
Thank you, Dr. Agarwal, for the kind introduction. Good morning, everyone. I'll be speaking to you on traumatic endophthalmitis. So traumatic endophthalmitis, or more specifically endophthalmitis that follows open globe injury, is something that we keep seeing in our clinics, especially in high volume or emergency related setups relatively commonly. We have a lot of literature that is already present out there, so we will not go through a didactic regarding this. But if you look at what the literature tells us as a summary, we know that trauma is a grave condition. The vision gets a double hit. So you have vision loss due to trauma, and then you have vision loss due to infection. And time is vision. The earlier you manage these cases, more you are likely to salvage. Infection in these situations is often polymicrobial, because there is a whole gamut of things that can enter the eye and contaminate the contents. And you have often very virulent organisms like bacillus, fungi, or pseudomonas, which cause multi-drug resistant infections. More importantly, trauma also largely affects the young population, which in any society is the working population. So these injuries also have economic and social impact. So for today's discussion, we will look at surgical manipulations that we do in a post-trauma end-off setting. What is the rationale of each such intervention, and what are the learning points out of each situation? So first things first, when you're faced with a case of endophthalmitis with trauma after having secured the open globe injury, the second most pertinent step is to collect a sample or a vitreous biopsy from the posterior infected vitreous. So this is collected for microbiology, should be undiluted. So before you put the infusion line on, you are expected to collect the sample. Use a vitrectomy cutter rather than putting in a needle and aspirating, because if you aspirate, you're likely to create a pull on the vitreous. That pull can cause retinal breaks. Secondly, if the infection is very dense, just aspirating, you are likely to get a dry tap, so you're unlikely to get anything in your syringe. So it's always safe and always more effective to use a vitreous cutter. When you remove sample, it also makes space for injecting antibiotics, and as far as possible in a traumatic setup, if visualization permits, try to clear out as much vitreous cavity as possible. So this photograph demonstrates the setup that we have for collecting a vitreous biopsy, and we follow it up in this video. We will see how the vitreous biopsy is sort of collected. I'm sorry, I don't know why the video is not playing. Can anyone help? Sure. I think these are embedded videos. Yeah, but I don't think any of these are playing. May I just, Dr. Rupesh, if it's fine, may I sort out from my hard drive, because I don't think they're playing for some reason. I have on a... Yeah, I did escape, but so this is escaped.
This is a Mac?
No, this is a Windows. No, it's a Windows. Windows.
While the video issue is being sorted, just some of the tips, or probably we can take up some questions from the audience. If you have any specific questions for our panelists here related to trauma, Dr. maybe Amre, you can say some thoughts.
You just check where
The
is you
trauma
located the
management
video.
here in
They are embedded inside.
Middle East, yeah.
Why not?
Anyone have to ask questions for Ali? I have a question actually for Dr. Rika, if you allow me. You are talking before, I saw you are making a suturing of corneal, and you say you want to make it in a separate spacing between each stitch. right? What you have said, the normal way, right? But sometimes, you know, the wound is not regular that you can do. You have sometimes what you call Mercedes shape. So how do you manage in this case? I mean, it's not easy. The wound is not as we wish, not a surgical cut. So can you give a hint about this one, please?
Yeah. So sometimes the wounds are stellate kind. Sometimes you have to
I
take
just
a
played it sitting there.
bursting type of suture in case of stellate wounds. But try to see the edges of the wound and try to take the first bite at the acute angles of the wound and then try to fix the other areas, because there's always a wound which has little acute angles, and try to take first suture there. Or in cases you may have to take a bursting kind of suture in such cases where the wound is not linear and regular. Any?
Just,
Actually, basically, there are a few tips for managing it. One is, as you have said, that wounds cannot be at our wish. They can be of any shape and any size. So we have to place at right angles to that right at the right angle perpendicular to the wound. So it may be as per the shape of the wound, which is like that. If it is irregular, so you have to make the sutures, place the sutures along the 90 degree of that line of this thing. And it should go 90% depth of the cornea. That is also equally important. Our inner part should be equidistant. We should not make it that the external should be equidistant on the two sides of the line of wound. It should be equidistant from the inner aspect. Maybe from outside it is 3 millimeter away from the line of cut, and on the other side it is 1 or 1.5 millimeter only. And as a House technique is there, that is the peripheral suture should be larger, and when we go to the center, then the suture should be of the smaller width. That is what another thing is there. And one last thing, Dr. Rekha has said, our first suture, if our limbus is involved, should be at the limbus. First suture should be to make the limbus, complete the limbus, and then our suture should be at the acute angles. Wherever there is acute angles, then we should place the next suture over there, and then you fill in between. That is what it should be. That is the principle.
one just small thing, as to continue with Dr. Amrish, is I go for principle of halving. You divide the irregular wound into multiple wounds. So if you have zigzag wound, you make it into small wounds, and you take the sutures perpendicular to make it a small segment of the wound. So sometimes it's a long wound, I make it into 3 or 4 small segments, and each segment becomes an independent wound by itself. You have one suture on one end of the wound, small wound, and one end of the another wound, and those are perpendicular, and those 3-4 segments can be irregular, not in continuation of each other. So that's a small.
I think maybe if you allow me, I know you are more expert, but we need to talk about those. They are not like us. We are not expert like you. What I'm doing sometimes is, you know, the first important thing is that you want to form the AC so that you can take the suture in a proper way. So sometimes you have to take whatever you can take, 2 or 3, which you are going to remove them. Yes. After that. Then after that, you can start figure out how you will make the stitch, and you have to take it longer. You know, it should be longer as maximum as. Then you can see how you can manage. And sometimes it is difficult, you know. We are talking, you know, because sometimes, you know, one from here and one from the other one. So it will not be, sometimes you have to take one long, just, you know, to make all the 3, because sometimes, you know, in the middle there is an area, wherever you do, you cannot figure it. You don't know where to suture. So you have to take from one, then second one, to go to the third one. So to make this stitch, I don't know if that's applicable or you have an idea about it, how to do it. Because sometimes even you cannot reach it by the needle itself, the wound is longer than the needle itself.
Okay, so I think those are correct points and really correct. So Vivek, we should go ahead with your talk, or should we get Kuldeep too? Or we skip the video?
Present my slides.
Slides maybe, yeah.
My videos are unfortunately for some reason not working.
Sorry for that technical thing, but yeah.
Dr. Mohammed, You are absolutely correct, and that sometimes it is not possible. We will discuss out at the end of the talk of Dr. Vivek, or if you get in time. No, at the end of the session.
Right, so, yeah, well, I will pull out each video. So this is how a vitreous biopsy is taken. You have put in an infusion line which is off right now, and then the surgeon puts the cutter on, and as the cutter is put on, the scrub nurse will then start aspirating the vitreous, and you collect it into this 2 cc syringe. And you then split off the sample and use it for smear and your culture creation. So this becomes one of the most important things that one needs to do in case of an endophthalmitis, that is collect a vitreous biopsy. Following that, like I mentioned, we need to do a complete vitrectomy as far as possible, because this is a setup which is very infectious, and as much you clear the vitreous, that much there would be a benefit for control of infection. PVD induction, though a controversial step, personally I feel if done carefully and slowly, it allows you to separate out the posterior hyaloid effectively, achieve a good clearance of the vitreous cavity, see the retina, and helps you finally in prognostication. Now, this is what the eye finally looked like. So take home in a situation like this, whenever visualization permits, clear the vitreous cavity to the extent possible. PVD induction, when done in a controlled manner, is safe and effective. It deloads the vitreous cavity and allows for inspection of the retina for prognostication. Second situation that we often deal in trauma is anterior segment exudates and anterior segment membranes, as seen in the photographs in these two cases. This is often seen in endophthalmitis where the anterior chamber inflammation is high, or say there is a background diabetes mellitus, or there has been a lot of iris manipulation surgically, or there has been trauma which involves the iris. So these membranes interfere with posterior segment visualization, and if collected, they also act as a source of good microbiologic sample. Once cleared, they allow the pupil to open up, and hence, as far as possible, they should be attempted to remove. If you can see from a side port using a 26 gauge needle, it is easy to find a cleavage plane between the iris and this membrane. And then once you find that, with slight aspiration on that needle, the membrane would get engaged into the needle to be able to effectively sort of clear it around. Once the plane is achieved, further viscoelastic injection and using a second instrument like a Sinski, you can completely clear out the membrane all 360 degrees and then manipulate it towards the same side port, pull it out via LIMS forceps, and just plate it on an agar plate right there on the surgical table. This again is what the eye looked once everything was cleared out. So AC membranes as a take-home are easily cleaved off the underlying iris. The trick is to identify a perfect dissection plane, and a combination of a 26G needle, viscocannula, and LIMS forceps can be used. And the sample that is achieved can be directly plated on the agar plate. Lens abscess is another presentation which is often associated with endophthalmitis in a setting of trauma. If you look at these two photographs, the one on the left is a posterior lens abscess which comes as an endogenous infection, while one on the right is a post-trauma lens abscess. Very classically, you see an entry wound on the cornea, and then you see a lot of fluffy matter which is exposed out and surrounded by yellowish creamy lesion in the substance of the lens. So lens abscess is an infectious clinical presentation of purulent matter in the substance of the lens. It can be a complete involvement of the lens or focal yellowish creamy lesion. And most importantly, it requires a complete lensectomy for appropriate clearance of the infectious focus. This we have published recently as to what are the outcomes when you manage it in a complete removal. So short surgical video again to show how you would go ahead and approach this lens abscess. With an instrument, you sort of dissect off all the amount of abscess that is present and clear it out. Once that is done, extremely important, the underlying lens needs to be removed. If it is a soft lens, like it was in this condition, you can do a lensectomy. And if it's a hard lens, then you can actually make a small incision cataract surgery tunnel and deliver it out through the tunnel. But most important, the entire lens the entire posterior capsule and zonules, the whole complex needs to come out whenever there is a lens abscess. So location will depend on the mode of occurrence. Exudates will look connected to the crystalline lens, and complete lensectomy is a key. Last situation is use of an endoscopic approach. This is a patient with a blast injury with multiple small corneal tears, corneal edema, anterior chamber exudates, and as the B scan is showing you, multiple foreign bodies. So this is a situation where since the last 4 or 5 years, I'm comfortable entering endoscopically because of the good visualization that it permits. As you can see here on your screen, the endoscope allows good clearance of the exudates, and like in trauma, you can expect anything. So here I see an eyelash which is present in the vitreous cavity. At the base of the lash, we can see these foreign bodies which were visible on the B scan. And as I mentioned, it was a blast injury, so multiple such foreign bodies would be present. So there is a meticulous need to clear out, search in the entire exudates, and this is what I find: multiple small, large, and small foreign bodies. Once separated, there was a thought that these would be magnetic. Unfortunately, they were not. The magnet did not attract them. So in this situation, what we had done is I used an ILM forceps, because these are very small foreign bodies. Holding them with a foreign body forceps is difficult. So you can just take an ILM forceps, spread out its prongs, and then use them as something to pick up these foreign bodies, bring them up and rest them on the iris, and then from an SICS tunnel, pull it out via a McPherson's forceps. So finally, again, this patient finally ended with a vision of 4/20, and cornea, if you compare with what it was before, has largely cleared out and a well oil-filled cavity. So take home from this case, visualization is paramount in a traumatic endophthalmitis. If media is not clear, endoscopy can be a game changer. Retinal detachment can sometimes occur in these cases. It was there in the video, but for the sake of time, we've moved forward. This detachment can occur once you remove the foreign body. So this is important to remember. Originally, the retina may be attached. When you are doing that manipulation of removing the foreign body, there may be a full thickness hole below which would get exposed. And now the cavity is actually a fluid-filled cavity because you have also removed all the vitreous. So you may end up having a bullous retinal detachment on table subsequently after you have removed the foreign body. So you should be prepared for that. And one of the best ways to be prepared for that is to keep perfluorocarbon liquid at hand, which acts as a good third hand to flatten the retina down so that you can manage it appropriately with the laser and silicone oil. So finally, I would like to conclude by saying that in trauma, and especially in traumatic endophthalmitis, it's a situation of horses for courses. Each situation would be unique, and depending upon what you are facing on the surgical table, you would require multiple different combinations of manipulations for optimum outcome. So sorry for the technical glitch, and thank you very much for your kind attention.
Thank you, Vivek. And I think he has put up very nicely and with a lot of take-home messages in between each step of the retina, and very nicely presented. And just because we are running really behind the schedule, we'll get Kuldeep to get started with his talk on if everything is not going right, how do you rehabilitate, particularly cosmetically, a patient of a trauma. And that sometimes is a very ignored aspect of the trauma. We try to salvage, but what if nothing works out? And is there something we can do? And I think that's where Kuldeep comes as a finisher and kind of help some of those patients who have lost all the hopes. And I know we are running short of time, but if there are certain questions, we will try and take it up at the end of the thing. Okay, Kuldeep.
Thank you very much, Dr. Rupesh and Dr. Aberi, for inviting me for this wonderful meeting, and very happy to meet a lot of colleagues and friends which are missing for almost 3 years, not to see them. Well, welcome to Hyderabad. This is a Statue of Equality, which is one of the very fine monuments which built in South India, and a lot of people are coming. And I wish that someday all of you also visit Hyderabad in coming future. I do practice in Hyderabad, Kuwait, as well as in Houston. I have 3 continental practice of experience for last 24 years. And as we discuss about the different modality of treating the patients, of treating the surgical corrections or the VR surgery or whatnot, but at the end, anytime the patients have no choices, but they lose the eye, and it's very unfortunate for the parents, patient, or the family member too. What we do, basically work on the prosthetic eyes, where we are working on the digital dynamic or the digital eye process, where we are taking the photograph of the iris, and we work on that part for last 8 years in the country. But like in the trauma, you have a different kind of variants which can keep coming. So you have a problem, a defect with the maxilla or zygoma or orbital rims or whatnot, and it's need a lot of technical corrections as well. So not all the time you have a perfect surgery, but you have to aim for the perfection on the cosmetic outcome, what you can achieve these patients. And here I come in the picture, but also many of the conditions like the regular surgical trauma will not, regular surgical procedure cannot help you, and you have to think out of the way. So this is actually a radical understanding about the talk, and we're talking about like what happening with the trauma, like you have the damage of the rim, or you have to have a very radical surgery where you need to remove the entire content, or also the eye become thysis, or also sometime eventually doing the inoculation or evisceration and placing a orbital implant. And this is just an illustration about what you see after all the surgical procedures done for the patients. So the simplest ways for this kind of patients, when actually the eyes start going in thysis and there is no pain, people actually could be able to take a measurement and work on the wax prototyping, and could be able to design a nice process with them, and actually you're able to restore their cosmetic appearance and their confidence too with that way. So my simple way is that, not every single patient need to go for a surgical consideration, but yes, if the case is actually very mild volume loss, is the first choice is always a custom skull shell, where you design and take a measurement to them and you define it. But also sometimes the volume loss is significant, but not again, I would say the secondary or primary choice to go for inoculation. I still prefer to have an anatomical tissue content because you are able to have better motility of these patients. So again, I go for the primary choice is actually having the retention of the normal eyeball. So this patient actually have a very contraction of socket, but still we are able to achieve. And normally this kind of people go for blinking exercise and they achieve. But many times, like as I said, there is no choices. Eye become very painful and patient have to undergo for surgery. The surgical choices, you have a choice of going inoculation or evisceration, but many times in the trauma patient, because of sympathetic ophthalmia, people prefer to do inoculation. And we have worked a lot actually on the different kind of surgical technique of inoculation with our colleagues in LB Prasad, with Dr. Honover, and many other colleagues, and for last so many years. And we talk about the myoconjunctive inoculation, where you are actually attaching the muscle to the fornices, able to provide the volume support as well as provide the better motility for these patients. So this is a patient having a simple polymethyl methacrylate implant, and you see this how well is the fornix is moving, and similar with the process actually I was able to get. This patient had a very serious injury, and there was no choice that we actually will get any kind of motility with these patients. So now how the socket looks. So when everything is good, your aim is to have not only to have the comfort, but also make sure that the socket is very healthy. And that's what this is a patient after almost 2 years of using the process. Socket is absolutely quiet, no discharge, no inflammation, and doing very, very well. And this is how you should be looking and aim for the process. The process should be able to replicate your anatomical structure, including your limbus, your iris patterns, your blood vessels, sclerotons, every single damn thing what you see. But most of the time that you have because we see a lot of radical trauma patient, and in radical trauma cases, like having the tissue placement or having a position is very, very difficult. Many times you have a tissue which is start displacing it, and eventually you end up in actually the entropy and ectropy and the volume deficit with that way. This is another cases of actually had a bomb blast injury, then infected socket, and going for multiple back and forth, going on with this scenario. Also have very severe volume losses. So, like even though you place a largest implant for 24 millimeter, but still you have volume loss, and you have a choices to work sometime, like do a double implant, or even they're planning for a very large process, but eventually patient is not able to tolerate. So we actually work with the Botox and filler combinations too. So whatever the volume deficit remains, we're able to replace the volume loss along with the implant with the fillers. So as I said about soft tissue disorders and even the fornix, the band adhesions, the ones should actually look at for the modality very, very clear. So try to replace the volume as much as possible using a proper implant sizer where you are able to match the volume, what is deficit, use a correct size of implant. Make sure that after the surgery you are able to put a right size of conformer so that you don't have the contraction in the socket. Many times if there is an eye will exist and you see there is a cases of the chemical injury, you make sure that you put a fornix simply fronding so that there is no synechia or they simply for actually start forming with the surface with that way. So I also develop and invent as a device. It's called, it's made of polymer. It is actually a very flexible conformer. I'm not sure. Can you play the video? There's a video here. So this actually is a flexible device. Many times you happen when you are working for the traumatic cases, there is a lot of problem in the fitting the conformer, because if you are not putting a conformer in the place, the socket will collapse, and this is what actually do. So this is a very flexible conformer, and you can even cut and sizes the conformers so that you can work. So we also try to work on the volume replacement. This is patient come for second opinion, and we work on the things, and you are able to replace a lot of volume things, able to correct even the anaphthalmos appearance with them, and of course. So we also work on the deformity like the ptosis. So many times you have a residual ptosis which has not been corrected with the implant and process, but we design a different design of the process, and you are able to correct it. So this is a patient again with the injury, and she lost entire movement. I'm not sure whether the video can be played. So there is no LPA section, but yes, we could able to work on the design, and that you are able to open the process with the surface. In what scenario when nothing works, I work on the ptosis scratch design on the process shelf, and it's called shelf design, and you are able to even open the eyelids. This is a nice paper. Probably you were working on a lot of trauma cases. Probably you go to see, and that how you can do the volume displacement and actually restore the appearance with minimum surgical interventions. So this is how, working on patients. This is a case you see about the left eye having so much of the anaphthalmos and the drooping, and we are able to correct with the volume displacement technique too. And of course, we use a lot of optical illusions using the lenses, prisms. So like of the deformity, this is actually the trial of the prism, and then you actually put the prism over the spectacle in the form of present prisms, and you are able to replace the dystopia with that way.
Thanks, Dr. Kuldeep.
Yeah.
And this is really amazing, and I wish we could have continued with that. And there was some technical glitch, and I like to apologize to our next people who are sitting there, but probably they did not know there was some timing error where we could start only at 9:15 instead of, because our session was scheduled at 11:30. Anyway, probably you were not aware about this background. So I will skip my talk, and in interest of time, I will give it to the next panelist, the next group who have come. But thanks on behalf of APOTS to MUM for giving us an opportunity and giving trauma space between all the other subspecialties to present. Thank you very much.